Hi, this is Brian Kim. I'm going to share with you case number 56 in the best way to do cataract surgery series. This is a moderately dense lens with a small pupil, and you're going to see double chop, cross chop, mechanical fracturing techniques, but you're going to also see very careful vacuum control to make sure that I'm not near the iris with the phaco tip. When I activate the vacuum, you're going to use mechanical fracturing forces when I'm near the iris for a more exquisite control, and then also using the chopper as a buffer to protect the iris. So I'm using a cotton tip to center the eye, and then I'm using a corneal marker, which will help me to center and size the rexus. This patient has a pretty aggressive Bell's reflex. This is a right eye. Eye is being turned upward, which is okay. I'm supporting the eye with the cotton tip and then entering for my paracentesis. Again, this is a paracentesis incision flat to the iris plane to create a nice corneal shelf. I'm having to tell the patient to look down because the patient's looking upward so aggressively. I'm using a cotton tip to support and stabilize the eye. And then again, I make my paracentesis flat to the iris plane for a nice corneal shelf. I'm injecting some intracameral lidocaine and then intracameral epinephrine. There was not much effect with the epinephrine. I inject some dispersive viscoelastic, and this is a triplanar corneal incision. I make a vertical groove, turn the eye away from me with the cannula, go into the deep part of the groove, tunnel through the cornea, use a cannula to turn the eye towards me, and then enter. That's a triplanar corneal incision. This is my puncture style capsulorhexis. I'm supporting the eye with the cannula because I'm afraid this patient's going to look up again. So I did the puncture technique, grab the right side of the tear to create a flap, and I'm going around circumferentially, again, using the cannula to hold the eye straight because this patient does have a strong Bell's reflex. I'm grabbing and re-grabbing. Again, in this case, because the pupil is a little bit smallish, I'm able to use the pupil size to help me with the rexus. So again, I did that fairly quickly because this patient is not really very reliable. As soon as I take my instruments out, you can see the eye turns way up. So this is the capsular fornix hydrodissection technique. I place the cannula out underneath the rexus edge, conjure incisionally, point the tip down, get a nice fluid wave decompress on the left side, turn the tip down and towards the right. You can see the lens starts to spin quite nicely. But again, you can see this patient has a very aggressive Bell's reflex. So I'm irrigating the surface of the cornea and adjusting my sleeve to the appropriate length. I lift the incision with a chopper, go in with irrigation off to minimize Descemet's trauma. Now that I have 2-point fixation with 2 instruments, I have better control of the eye. Remove the surface epinuclear material, place the chopper out, point the phaco tip vertically subincisionally, bring both instruments together, and it crushes the lens in half. That's the double chop. Place the chopper around the right heminucleus, pulling it centrally, crushing it. That's the cross chop. You can see there's quite a bit of density when I crush that lens material. I use high vacuum as well as a chopper to pull that first quadrant up, and I'm crushing it with mechanical fracturing forces. You can see I'm using the chopper to protect the pupillary edge. And again, when I get the phaco tip close to the iris edge, I do not use the vacuum and aspiration. I turn it off when I get close to the iris. That's very important. Place the chopper around the second quadrant, pulling it centrally toward the phaco tip, and that divides the lens piece. Using high vacuum, I pull that fragment up, and I'm using the chopper to, again, support and protect the pupil edge in that area. Place the chopper around that second quadrant again, crushing that lens piece again in half and breaking it up into small pieces with the cross chop maneuver. I'm using mechanical fracturing forces to crush the pieces into smaller pieces. And again, with smaller pupils, I like to use the chopper to hook pieces and pull them centrally rather than chase it with the phaco tip and high vacuum. I don't think using high vacuum is a smart idea in a small pupil. Sensing that the pupil was kind of getting smaller, I put more viscoelastic into the anterior chamber. I turn the second heminucleus in front of me, place the chopper around the lens piece, pulling the chopper centrally toward the phaco tip, crushing it in half. I do the same maneuver around the third quadrant. start to use some high vacuum. You can see all that viscoelastic around the iris and lens piece, so the iris was pretty reactive. So I'm using, again, the chopper to support the pupillary edge to protect it from the high vacuum, grasp that part of that third quadrant, pulling it centrally, and then using mechanical fracturing forces to crush the lens pieces. This is the final quadrant. I'm placing the chopper around the lens piece, placing the phaco tip vertically, crushing the lens between the chopper and the phaco tip, using mechanical fracturing forces to sandwich and crush the lens pieces into smaller pieces, being careful and mindful to use a chopper to protect the pupillary edge from the phaco tip with the high vacuum. So again, using the chopper to protect the pupillary edge, and also when I'm doing mechanical fracturing maneuvers, I make sure that there's no vacuum activated to protect the iris. So I'm using high vacuum to grasp the epinucleus, which tumbles out. You want to grab the epinucleus from the anterior edge of it. So I take the chopper out, push BSS in, take the phaco tip out, and push in the INA handpiece. I'm just positioning the sleeve to be more appropriate. I start subincisively, sweeping side to side, making sure I'm grasping the anterior portion of the cortex so it peels from front to back. Again, going for the subincisional material again. You can see most of the cortical material around it starts to tumble out quite easily. And that's because of good hydrodissection. I switch to the polish mode, again, because the pupil is small. I don't like to use high vacuum in this setting because you might accidentally grab the bag and stress the zonules. You can see I'm polishing the posterior capsule now, being very gentle again on this polish mode. It's very safe, and I'm not making any very aggressive maneuvers, just kind of small, gentle side to side and circular movements to tease off any lens material off the posterior capsule. I sense there's a little bit of cortical material there, so I switch to the cortex mode in this area. And then switch back to the polish mode. Once I'm satisfied that I got everything, I'm going to go into the subincisional space and pulse with the BSS cannula to make sure I flush out any subincisional material. It looked pretty clean there. And then I'm going to inject some cohesive viscoelastic to fill the bag. And I'm going to use the capsule sweep to sweep on the left side, underneath the rhexis edge, and then on the right side. I don't want to be too aggressive in these cases when the pupil is a little bit small. So I'm going to inject a single piece acrylic intraocular lens into the capsular bag. The leading edge goes into the bag. The trailing edge is out of the bag. And then I'm going to go in with the INA with irrigation off first, and then activate irrigation, disengage the leading haptic off the optic. The trailing haptic came off already, going underneath the lens, tilting it, rotating it 90 degrees clockwise. While it's tilted, I remove all the viscoelastic from within the bag, reposit the lens back into the bag, making sure that the lens is completely in the bag. I go back underneath it because I saw some very fine lens material, some wispy material between the lens and the posterior capsule. I'll go ahead and remove all the viscoelastic from the anterior chamber. I'm tapping the lens gently to make sure it's nice and clean and seated well. Push BSS into the angle to pulse any potential viscoelastic out. Take the INA handpiece out and hydrate my incision. So you can see I perform double chop, cross chop mechanical fracturing techniques, in this case of a dense lens and a smallish pupil. With small pupils, you just have to make sure you don't bring the phaco tip near the pupillary edge. That's why mechanical maneuvers like chopping and using the chopper to hook the lens pieces up out of the bag, using the chopper to protect the pupil as well. All of these maneuvers just allow you exquisite control You're really not handcuffed by having to use the phaco to do a lot of these maneuvers, because if you use high vacuum in this setting, you can get into trouble. That's why mechanical techniques such as chopping and hooking pieces up out of the bag, protecting the bag, in my opinion, is so much more advantageous and a much more versatile way to deal with dense lenses and small pupils. So I hope this was helpful to you, and I thank you for your attention.